はい、皆さん、こんにちは。グリーンゾンジャパンのミキです。オレゴン州では2023年にシロシビンを使った精神療法が合法化されました。で、昨年はポートランドにあるイマーシブセラピーという治療センターを取材して動画をお届けしましたけれども、今年も引き続きオレゴンの取材を続けています。で、今日ご紹介するのは、エンドオブライフサイケデリックケアという非営利団体の創設者であり、終末期医療にシロシビンを取り入れるための教育啓蒙活動を行っているクリスティーン・カルドウェルさんです。終末期医療というのは、回復の見込みがない患者に対し、延命治療を目的とした医療行為を積極的には行わず、身体的、精神的な苦痛を緩和し、残された時間を自分らしく過ごせるように支援するというものですけれども、シロシビンは依存症や PTSD の治療のほか、この終末期医療にも利用されているんですね。で、死を前にした患者さんは往々にして実存的危機と呼ばれる精神的苦痛に直面するわけですが、そういう患者さんに対してシロシビンを使った治療がどのように役立つのか、そのお話を伺いました。
My name is Chris Caldwell, and I'm the founder and executive director for the nonprofit End of Life Psychedelic Care. My background is primarily in business. And so I was actually in Silicon Valley as a marketing executive in high tech. And then I moved to Florida and I owned and administered a home health care agency. So that's where I first began to really care about and care for and understand what it means to care for older adults who wanted to age in place. So then fast forward to 2020 when I began to study psychedelics, and I really didn't know what I was going to do. But in the midst of this year-long psychedelic training program, then I was thinking about my background, and then it became almost a no-brainer. Like, oh my goodness, I've got a business background. There is this clear need to talk about psychedelic care at end of life, which let me define that. That typically means anybody with a terminal illness or life-threatening illness who's facing death anxiety and other issues associated with, facing your mortality. So I founded a nonprofit because I also wanted to offer as many services for free and to offer our professional courses for as low a cost as possible. So that's what brought me up to like founding End of Life Psychedelic Care. I think part of that though is, I gravitated towards the research, the earlier research, and what I call the modern era of psychedelic research was in the early 2000s. And so UCLA and NYU and Johns Hopkins were in the forefront of that research, and it was all psilocybin. And interestingly enough, in the 50s and 60s, when they were using psychedelics to help people with death anxiety, it was LSD. Well, it's much easier to get approval, first of all, for psilocybin, and secondly, the journey is shorter. But, beyond that, I mean, we know that there's ketamine that also does an excellent job, and each of these medicines are different, but there's also MDMA, and then there's also 5-MeO-DMT that I'm familiar with. Now, there's other psychedelic medicines that people may choose to use, but those are the ones I'm most familiar with. One of the things I do a lot is connect people together. So I have a pretty phenomenal database of professionals, and I'm always connecting people with each other to further advance the field. If I were to step back and say, my nonprofit has 4 pillars. So the first one is education. And as I mentioned, in terms of wanting to offer free programming, so we do a number of free online events, and then I have the professional courses. My second pillar is connection, actually, and we have the only practitioners directory that has both, the people listed in the directory have to be experienced in both end of life and psychedelic care. Now, they could be hospice physicians, hospice nurses, social workers, end of life doulas, or chaplains or spiritual counselors, for example, but well versed in what it means to work with somebody who's faced with, again, mortality. And then, of course, they have to have experience in psychedelics. And then the other thing we do relative to connection is offer a online support group. So again, anybody with a terminal illness or is a cancer survivor, for example, it's a safe environment for people to share, people who understand the issues, and we can talk about psychedelics in this online support group. And then the third pillar is advocacy. So I do whatever I can in the US to help advocates, whether that's on the federal level or on a state level. Here in the state of Oregon, as we speak, in-the-home psilocybin services is not available. So there's work underway to try and amend the law to allow for in-the-home psilocybin services, which we feel it is really critical for end of life, but much more. I mean, those with disabilities, whether they're physical or mental, developmental disabilities, it's really important to be able to have that service. In Colorado, because they came later and they kind of learned from what Oregon did, they do offer psilocybin services in the home. So that's advocacy. And then the fourth pillar really is looking to advance the field in terms of research or providing resources. So I'm in the middle of a study with the University of Chicago researcher. We called it Psychedelic Death Worker study. And so we surveyed 100 people, and then we conducted an additional 35 Zoom interviews. Dr. Ian was one of those in the Zoom interviews. So we learned a lot from those folks, and to me, it's going to be really instrumental in informing the approach to this care, and also training, because there are unique considerations when facilitators are working with people toward the end of life.
So you don't have your own clinic or service center?
No, that is correct. End-of-life psychedelic care is a nonprofit that, like I say, is primarily educational. We do not offer clinical services, nor do I expect we would, because there are other people locally. See, we're worldwide, actually. You know, so everything we've done to date is online. So, but again, I'm working with all of the either licensed service centers, as they're called here in Oregon, or healing service centers, as they're called in Colorado. So again, I'm working with them, I'm connecting them, I'm connecting clients to them. So that's what I feel my role is. Yeah, psilocybin has a lot of wonderful benefits for people toward the end of life, and I want to say unequivocally, psychedelic medicines are not for everybody. And one of the things we make sure is we talk about the need for collaboration, the need for medical clearances, for example, from physicians or from pharmacists that specialize in psychedelic work. So that's really critical. But setting that aside, you know, people's intentions when they come to this work varies a lot. And I'll give you an example of someone who had the great benefit of evolving his thinking. The gentleman, Thomas Hardle, is the first Canadian who was approved for psilocybin therapy through a special access program in Health Canada. So that's for people with life-threatening or serious illnesses. And between 2020 and 2024, he participated in 7 psilocybin journeys. And it was almost like a Maslow's hierarchy. I mean, I don't know if he would describe it that way, but initially his intention was to reduce debilitating anxiety, because as soon as he received his stage 4 colon cancer diagnosis, his anxiety just spiked, and he felt he wasn't able to be there for his family. He was all wrapped up in negative energy. So that was his first intention, and it was amazing on the scale that they use, and I believe it was the GAD-7 scale, General Anxiety Disorder Scale, that he went from a 36 to a 6. I mean, just phenomenal, one psilocybin journey with psychotherapy. And it was group therapy, which I'd like to come back to in a moment. But then as he began to explore more and went through more psilocybin journeys, then he began to elevate his intention. So it was a sense of, I want to feel the consciousness. I want to know that I'm more than this body. And he got to the point where he says he was a panpsychist. But a follower of panpsychism, where everything has a consciousness. And like many people with cancer who participate in psilocybin journeys, they confront their cancer, because psilocybin, unlike some of the other psychedelic medicines, makes you confront things, and among other things. But he was able to have a dialogue with his cancer, and his cancer told him, do you think I want to be here? I don't want to be here. He called his cancer almost me. He understood it was a consciousness. And he also said that I would not be the person I am today if it was not for my cancer. I became a much more spiritual person, and I'm a different person, is primarily what he said. So he lost his fear of death. By the way, his spouse, I believe, also participated in psilocybin journeys, so she began to work on her own sort of anxiety and fears about losing Thomas. And he did pass in August of 2024, but he has left a tremendous legacy for people to learn from him. Another thing I want to share from him, he has this lovely analogy. I tell people this all the time. He talks about a bucket of iron filings. He goes, what is a bucket of iron filings? Nothing but this metal. He says, you melt it down and make a tuning fork. Well, you have this lovely tuning fork. But when you strike it and you send the vibration out into the universe, that lasts forever. So this is how he came to understand his life, again, and his legacy. Now, other people are using psychedelic medicines to heal, and I don't mean heal the cancer. And by the way, I would like to add, one of the things that Thomas was adamant about is the fact that it allowed him to move that negative energy to a healing energy. And he attributes that for outliving his initial prognosis, which was 18 months. He lived for 8 years. So he felt in shifting to positive energy, he was able to much better handle and live life, and live life. So, some of the other intentions, though, because people do come in with different ones. I want to heal relationships. I have guilt about something I did. I feel I need to forgive somebody else, for example. My family relationships are in disrepair, for example. Then there's the whole point of I'm losing control. I'm losing control. Let's say I used to be the matriarch of my family, and now I'm not. And it's like, what's going to happen to them? Well, I mean, we know they're going to be fine, but if you were the matriarch, you really start to worry. And people also come into it to when they lose a sense of purpose, as you can imagine. It's not just losing control of your life, but it's also like, my life has no purpose, my life has no meaning. And medically it's termed demoralization. So in a way, we say things like, to die well is to live well. To learn how to die well is to live well. And then there's the famous saying in Greece about, once you die before you die, then you won't die when you die. Kind of, yeah. And it's really true. So people have found an improved quality of life. They have found their relationships have improved. They have found that they can take back control of their lives. Now, and that's always been a paradox to me, because you think about it in terms of Buddhism and the importance of surrendering. You cannot control the fact that you have a cancer diagnosis, for example, and your life has been shortened. And so to surrender to that, like in the example of Thomas, is really important. But it's also important a lot of times when your family wants to dictate your care or dictate decisions for you. And it's like, no, I want to take back control of my life, while I'm living, basically. So yeah, I mean, there are several different intentions that people bring into these psychedelic journeys, and many of them benefit. Again, we're not going to say that 100% of the people benefit, and some of the journeys are challenging because they may be uncovering trauma that many of us suppressed for a reason, and we don't really want it to surface, and it will sometimes. And so this is why it's also important to have a trained facilitator, a psychotherapist, or other person, a spiritual counselor, chaplain, to help you work through that trauma. Which brings up a whole other thing about religion. Some people in the Christian faith believed they may be damned and going to hell. So they need to forgive themselves about that and lose that fear of thinking that they're going to go to hell. But if I could sort of extend it to some of the other psychedelic medicines, because as I said, they are all different. So as psilocybin is this one that can provide a unity consciousness and this ability to confront your issues, then something like ketamine, that's also been used with great success, is a dissociative anesthetic. And so it allows for people to sort of separate their mind from their body, and then two things happens. It puts them into an observer role, and they can more objectively look at their life and deal with their issues that come up. And also they get a sense of what it means to die. Many times it's like a practiced death. And there was a study, I think of some 15,000 participants, that found that ketamine was most like a near-death experience. And a near-death experience, in turn, is a lot like a psychedelic experience. So I don't know about you, but I would rather do a psychedelic journey than have a near-death experience and not potentially come back. So ketamine has that ability. And the other thing that's so great about ketamine that's been proven is it reduces severe chronic pain. So chronic regional pain syndrome, for example, very terrible. I mean, people can live with pain levels of 8, 9 out of 10. And typical medicines, opioids, don't cut that pain. Ketamine is amazing. Now, ketamine, we say, is fast acting and short lasting. So you might need multiple dosing sessions of ketamine, which is okay, but it reduces that chronic pain. And so we all kind of know that when there's chronic pain, there's higher levels of depression. If you can reduce the chronic pain, you reduce the depression. If you can reduce the depression, you can reduce the chronic pain. And that's not even getting at spiritual distress. And now not just ketamine, but all the psychedelic medicines can help reduce spiritual distress, which has been shown to reduce the pain. So that's ketamine. Then there is MDMA, and we say MDMA is an empathogen. So that's a heart opener. And it provides other compassion, self-compassion. So this is, like I said, when people come in with intentions to say, yeah, I need to forgive myself. I think to have a good death, I need to forgive myself for things that I did in the past. It can help you with that. And it's very different. You're not having the same kind of mystical experience on MDMA. You're coming back and you're facing your issues, and you're able to review them without the fear, because the thing about MDMA, it actually increases the activity in the prefrontal cortex and reduces the fear center, the amygdala. This is why MDMA has been so perfect for PTSD. For anybody who's been affected by domestic violence or by abuse or by being a veteran and being in combat. So MDMA, really great. And then there's also 5-MeO-DMT. Now this is a potent, arguably maybe the most potent psychedelic medicine out there. But what's great about it is it can be used very close to end of life, very small doses 5 milligrams. The journey arc is 15, 20 minutes. And the person, I mean, it's known, it's called the God molecule. And so it's known to shoot people into, unity consciousness and deal with other of their issues as well, their fear of dying. But again, it can be used pretty close to end of life. So you've got this, and if you look at it as a continuum, and I want to come back, your readers and viewers are really familiar with cannabis medicine. And so cannabis is tremendous for people, again, with chronic pain and people with anxiety. But it serves to a point. And so for more relief, maybe from chronic pain, as I said, ketamine, and there are now studies underway for psilocybin, but we know ketamine for sure. But to actually launch into that, unity consciousness, then cannabis typically does not get you there. So it can reduce the anxiety, but if you want to go farther, then see it as a continuum of medicine. Move from the cannabis to psychedelics. I mean, you can do them in parallel, right, to still reduce pain. But I just think it's wonderful if we could all have all of those options to help us. And, the main reason why I founded this nonprofit was to really reclaim death and dying as a sacred journey. I can't speak for the whole world, but I can speak for here in the US and some of the Western world, Western Europe, North America, the US. We treat death as something to prevent, and it's like a failure if a doctor allows his patient, her patient, to die on their watch. And so, it becomes a way of how do we prolong life? And as you know, we've got the technology to prolong people's lives way past when they have zero quality of life. And if we can help shift an understanding back to death as sacred, then I think the world will be in a much, much better place. So let's speak about spirituality, because it's been a bit controversial here in the States. There was a researcher who criticized Roland Griffith's work and Bill Richards' work at Johns Hopkins because he felt there was a bias towards spirituality, in part because there was a Buddhist statue in the therapy room. And maybe that's fair. I don't know. As a pure scientist, maybe that's fair. However, since I've had the good fortune of talking to hundreds of people and conducting a study with 100 responses all by itself, then spirituality plays a major role. However one defines spirituality, whether it's us sitting here in nature, right? It's beautiful. We have a sense that there's more, again, than just us in this world, and that it should be revered and held sacred as well. And when we were interviewing via Zoom, and when we conducted the survey, we found that the majority, if not every single facilitator, has a really strong spiritual background. Mostly Buddhism, or a practice Taoism, Advaita Vedanta, whatever. They have a history and a practice of spirituality. And conversely, I strongly believe that the reason why the psilocybin studies were so successful, some of them single dose of psilocybin, and folks were relieved of their depression, anxiety for years after, single dose with the psychotherapy, is because of the spirituality. Most everybody comes to it in this field because they want to understand that there's something more. They want to maybe even glimpse what the other side looks like. So they come into it predisposed with a spiritual belief. And even, there's, I think it was Johns Hopkins, where an atheist was quoted. And, after her journey, she's still an atheist. However, she has this sense now of the beauty all around us, and again, it's more than just us. So it has that power, and we know from the research that the higher the mystical experience, the greater the therapeutic benefit. So it all ties in together. So it's not even an argument from my standpoint. It's the most important thing when, again, you're faced with the fear of dying and the benefit of psychedelics. And I just wish that not only would I wish that everybody had these tools in their toolbox, but that they could do multiple journeys and, just like Thomas, evolve their intentions over time. Well, I'd like to speak in terms of what I'll call relative contraindications and absolute contraindications. So as you can imagine, people with a terminal illness experience physical conditions that may prevent. So a serious heart disease, serious asthma, for ketamine, severe bladder or liver disorder because of the way that ketamine works on the bladder. So we have to be careful from a physical standpoint. You know, most of the trials, all of the trials have ruled out any kind of psychosis. And most of them ruled it out if it was within your family and your extended family. So so anybody that is exhibiting active psychosis, totally no. The way Ben Malcolm, the spirit pharmacist, phrased it was in terms of the mental disorder. For mental distress that is more of an ordered one, like depression, then psychedelics is really good. If the mental distress is a disordered one, like schizophrenia, then no, it has that propensity to, disorganize your brain even more. So rule that out. Beyond that, family members can cause a problem. And I always tell facilitators when we're training them, you have to decide what happens if a family member says no. And your client is saying, but I want to proceed, because that family member could potentially sue you, and that not only that, sometimes it may require that you get their consent. So that's also a factor. We also are strongly stating from an ethical standpoint that the person has to be fully capable of making an informed consent, because we always get into the discussion about dementia. And there is a study in Johns Hopkins underway looking at early Alzheimer's and mild cognitive impairment. But those those participants have been able to provide informed consent. So at some point, when you're not able, when you could be deemed incapacitated, then it's virtually a no-no. One of the other things, again, if I look at then relative contraindications, depending on the medications, and some of the medications, are relative in the sense of let's look at opioids. Many people toward the end of life are on some kind of medicine like that to relieve chronic pain. And then we look at short-acting versus long-acting opioids, and because you really don't want to give the person their prescribed dose in the middle of a psilocybin session. So if they can use a longer-acting one, that's good for 24 hours, much better. Relative contraindication is the person's mobility, and it's relative in the sense of, again, this is a contract between the facilitator and the client. Are you going to be able to help that client transfer? We talk about transfer assist when they're not very mobile. Are you going to help them go to the bathroom? Is that something you want to do? Do you need to have somebody there to support you, and that the other person allows that? The other thing, this isn't a relative contraindication, but it's interesting. Almost everybody every experienced facilitator will also talk in terms of the client's readiness for a psilocybin journey. And I'm sure, Naoko, you've experienced this, where if the person is holding back and not truly comfortable enough to let go, whether it's because of the relationship with the facilitator or it's because of their own trauma, usually it's more that, or they feel that they have to not let go, then those people are not necessarily going to benefit from a psychedelic dose. Oh yes, yes. And here's another thing to note when you're working with people toward the end of life. Their metabolism doesn't work as well, their digestion doesn't work as well. And so if you're using an oral medicine, like here in Oregon, it's always an oral pill, and it goes through the digestive tract, and sometimes it's not metabolized well. And so we have stories where psilocybin was administered and there was no reaction. And in one case, the client, was sent off in a cab because hours had gone by and there was nothing. And in the cab is when their psilocybin journey hit. So another example, a more scary example, was a gentleman who was in his 80s, and he was given his initial dose. And again, here in Oregon, the maximum psilocybin dose is 50 milligrams of an analyte. So 50 milligrams is a pretty significant dose. So he wasn't given that. But let's say he was given 25 to start. Nothing. A couple hours goes by, and it's like, do you want another booster? And the client said yes. So I gave him a booster. Now, I don't recall if he gave him a third booster or not. He never went over 50 milligrams, but in the course of the one session. All right, all hell broke loose after the second or third dose. And the gentleman had a really bad journey from a physical standpoint. You know, it can make you vomit, it can give you diarrhea, and this poor gentleman had both. And he was totally wiped from that experience. And it turned out to be a 13-hour journey, essentially, you know, from start to finish, before the client could go home. So, you know, when I ask physicians about this, then it's like, don't give them any more. Say, all right, we tried the 25 milligrams. Let's leave it at that. Come back another day, and we'll try more, because then there's experienced facilitators who believe that it's the inability of the client to let go. So it's not a physical reason, it's for that reason, and you don't necessarily want to give them more. It's like, it's not going to help. Now, I'm sure you've got examples where it has helped, you know, but you know, not necessarily always. What that individual typically has been known to do is sit with an individual as they transition. And we have had birth doulas, like midwives, who helped, you know, with people coming into this life. And so then now there's people that are helping people exit this life, and to make their death as comfortable, to help them have the kind of death that they want to the extent they can. So what they do, though, I mean, doulas do all sorts of different things, but because I felt that they understand death, I mean, they have sat through transitions, that as a facilitator, they can handle anything that comes up in a psychedelic journey, because they've been there, they've done that, and they know what it means for people to die, so whether it's in a psychedelic journey or not. And they also, though, here in the US, their role has greatly expanded, so you don't have to be just dying to use an end-of-life doula. They can come in, they can help educate the family on death and dying, because here in the US, people don't understand, physically, emotionally, mentally, what happens to an individual as they get closer to end of life. So they can educate, they can be that mediator for, when I mentioned a collaborative team, so they can mediate between all of the different medical or mental health care professionals. They can also mediate family dynamics. There's a great story where an end-of-life doula was in a room with the client, and the family members were in the room, and they were creating a ruckus, and they were upsetting the client, and she shooed them all out. She tacked a meditation to the door, closed the door, and said, "Go do that meditation. You can only come back when you've done that meditation." And she explained how important it was for their loved one to have calm. So they can do that as well. They help a client with legacy planning. So here in our day and age, it might be video stories, interviewing and capturing a person's life in their own words on video or in photographs. And so helping them with that, and helping them say, how is it I want to die? And of course, we call them advanced directives here, where you can choose to have a do not resuscitate order. If something, if something happens, like you have a heart attack. And so a doula can help sometimes make sure that the family members and the medical care team understand that.
Is there a certification? Do you need
The
title death doula?
Okay, so here in North America, for sure, there is no licensing body. So it's not like being a licensed massage therapist, for example. So people will speak in terms of certification, but that's by organization. My course, for example, we issue a certificate of completion, and we encourage people then to be credentialed through one of the end-of-life doula associations, because that's a way to build your credibility and your credentials. But yes, actually anybody could say that they're an end-of-life doula, which is another reason why, for clients and their family members looking to employ an end-of-life doula, they really need to conduct due diligence. But the people that I meet, again, end-of-life doulas, they're spiritual, because almost every single one of them understands the importance of life, and they don't worry about the small stuff. They understand what's important, and they concentrate on that. And I just love that about them, in addition to being able to be there when somebody actually passes. So one of the things here in the US, because psilocybin is not approved through the FDA, many hospices will not talk about it. They won't talk about it at all. Now, there's other hospices in, I'll say, more friendly locations, Northern California, where psilocybin is not legal, where they may in fact refer, say, under the table. A physician would risk losing their license if they knew that they were referring their patient. But then in Colorado, because of the way that they've set the law up, it's going to be, not yet, but it's going to be probable to have the ability to have psilocybin in a hospice. However, hospice, I know, will not do it until it's reimbursed. And at the federal level, I would think reimbursement is going to take even longer than getting FDA approval. Hospices don't even prescribe ketamine for psychological and existential distress. They prescribe ketamine for terminal agitation and chronic or refractory pain, but not necessarily for psychological or existential distress. So, I mean, you've got some pockets, again, of hospice agencies that will do that, but more than 90% of them do not. The other good thing that we're hoping will happen is that in the state of New Mexico, they're allowing for a medical model. And that's a huge distinction, because Colorado and Oregon are non-medical models. They're adult supported use models. So in the medical model, as long as you've got the medical and mental health professionals trained to administer psilocybin, then yes, that can be within the context of hospice. But again, it's not going to be reimbursed. I just don't see it being reimbursed.
Sounds like hospice nurses are death doula, basically.
Yes,
And
yes.
they would be perfect people to administer.
They are, yes, and I didn't mean to not emphasize that. And hospice nurses, hospice chaplains, yes, they are excellent, which is another, I wanted to move the model, as we always called it, psilocybin-assisted psychotherapy, because here's another aspect of this. An individual toward the end of life may not need psychotherapy in the traditional sense of the word. They have existential distress. And so a psychotherapist may not be able to help them, depending on the modalities they're trained in. So you don't need a psychotherapist. I know facilitators. In fact, this one woman is a former nurse practitioner who says, if her clients need psychotherapy, she will refer it, but her practice does not include psychotherapy. She says people are coming to her. She has a coaching practice, but that's dealing with, again, existential distress. So again, I think it's options, right? It comes down to what does the client want and need, and can we then ultimately be able to serve both the psychedelic medicine and other forms of medicine in terms of spiritual healing for that individual.
Do you know Sunil Agarwal?
Oh yeah.
Okay.
Oh
I know
yeah.
him,
Oh, you do?
Yes.
Yes, and his clinic prescribes cannabis and ketamine, and he's the one who tried to prescribe psilocybin and is now engaged in the lawsuit. Yes. I love his clinic because he employs many naturopath doctors. In fact, the co-founder is an ND, so they bring that to their practice. Yeah, lovely man. I love Sunstone Therapies. They've worked with Johns Hopkins. In fact, Bill Richards, I don't know if it's proper to call him their lead facilitator, but Bill Richards is with Johns Hopkins, and Sunstone Therapies is in Rockville, Maryland, pretty much where Johns Hopkins is. And they are engaged in two different types of trials. They're engaged in trials with two different psychedelic medicines. One is MDMA, for exactly the reason I was talking about earlier. It was MDMA for couples therapy. And so one of the couple has to have a cancer diagnosis, and the other individual can be a spouse or significant other, adult child. And they both undergo the exact same MDMA protocol with the psychotherapy. And it is, in part, to look at relationships. And maybe not repairing, but deepening relationships. And MDMA, as we know, is really good for that. And then the other studies that they've done is with psilocybin, and they've done it where it's singly, meaning a client has a facilitator, and they're undergoing their own journey, or they have done a group. Their group is a blend of sort of one-on-one preparation and psychotherapy, and then they're in a sort of group. There was cohorts of 3 or 4 people. But the really cool thing about what they just published was that 24 months after an earlier study, they found that I think it was almost 50% of the participants were still reporting remission from depression, and still reductions in anxiety and improved quality of life. So 24 months after a single dose of psilocybin with the associated psychotherapy. But I am a big fan of a group model, and again I go back and I reference Thomas Hardle, because I had said that his first journey was, several of his journeys were in this group model, and that has so many benefits. And one of the major ones, and he also speaks eloquently about this, is that again, when you're sharing the same challenges and you come together, and they come together, it's an 8-week program, and their cohorts are 8 people, and they work together, they get to know each other, that when they go into the journey, they're actually almost going in as one. I mean, this is Thomas Hardle, who believes in unity consciousness and panpsychism to begin with. And it just makes their journeys deeper. You know, one person's crying, they're all feeling that. And then after in the integration, again, it's like they're all supporting each other. So I'm a big fan of that group therapy, and I'd like to see that model brought into the US. You know, we had our first retreat outside of Portland for cancer survivors. And I've heard anecdotal stories from the participants, and again, it was a very similar sort of model where they had a number of preparation sessions, the journey, and a number of ongoing support calls, group calls. So I think it's really important. Everybody has their choice. Do they want to do something individual? Do they want to do a journey in a group? They could do one-on-one, and then they can do another one, in a journey. But to have that flexibility and to know that there's that support group for you, I think is really, really important. I think a lot depends on the individual. Again, Thomas has said that when he had the advantage of the 7 psilocybin journeys, and a couple of them was with this group that I was talking about in Canada, and another one he went to Jamaica, and that was a mixed group. And he just didn't feel that cohesion, and he didn't feel he got as much out of that journey. So I would always say, if it's possible, yes. As Naoko knows, I would love to do, and she would too, a microdosing support group. And it's possible to do that here in Oregon. And it would be maybe one for grief, maybe one for cancer survivors, that would just be a low dose, microdose of psilocybin, and allow people to talk more deeply. Generally speaking, yes, because it's not like prescribing an SSRI. So I would say it's really better to do it. Now, people will say, I only serve medicine that I'm really, really comfortable with. So an end-of-life doula, she serves 5-MeO and MDMA and psilocybin. She will not do ketamine because she's not familiar with ketamine. And she doesn't do any other psychedelic medicines either. So there's that level of really wanting to understand the medicine. I think it makes them a better facilitator for sure. We know facilitators, psychotherapists who are good, who have not participated in a psychedelic journey. So I don't want to say rule it out, but I think you're a better therapist or guide or facilitator if you have. You asked a question about, You know, in Japan, there's, you know, people believe in panpsychism, and how do psychedelics help? You know, I have a thought that's borne out by research, actually, because, you know, what we know through the research is that there's, you know, they'll call it nature connectedness, and that obviously is you know, on a continuum. So people typically who use psychedelics have this close relationship with nature. Does it always extend into panpsychism? Maybe not, but it is on that continuum, you know, that can help. And I can't say, I've never done LSD, but I think LSD, of any of them, I'm picturing like allows the rocks to come to life. You know, hey, a rock is waving, you know, and so you might get a sense of that. Now, whether that translates into a panpsychic kind of viewpoint, I don't know. But we clearly know from the research and clearly know from anecdotal stories that people feel this sense of the nature and closeness to it, and Mother Earth. Big, you know, Mother Earth is to be taken care of. Yeah, we talk about climate change. I mean, you know, psychedelic medicines helping with, first of all, trauma over climate change as well.